Hi, hello everyone. Can you grab your seats? Hey, so welcome to the last panel, which I am really looking forward to. For those of you who don't know me, I'm Erica DiRuggiero, and I am an associate professor in global health at the Dell Atlantic School of Public Health, and I'm also associate dean of research and innovation. And it's really my distinct pleasure to introduce Dr. Theresa Tam, who will provide a presentation. And then after that, I'm going to be calling up three panelists who I'll mention in a moment, who will engage in a discussion with myself and Dr. Tam. And so we really look forward to also hearing your questions. Just as a reminder, because there are people online, when you are going to grab the mic, if you do ask a question, to make sure you speak into the mic very clearly so that people can actually hear you. So before I introduce Dr. Tam, I know she's sort of on the last runway for this particular job. And I feel like in public health, we don't do this enough. And having come out of a pandemic, I just want to take this opportunity to personally thank her for her leadership under very, very challenging circumstances. And so I think it's really important to recognize our leaders. There you go. That's all right. I didn't tell her I was going to do this, but seriously, I mean, it goes without question that she had to navigate very troubled waters. I know many of our public health leaders across the country did, but thank you for joining me and thanking her. So as I invite her to the podium, she has a very illustrious set of experiences and achievements. So it's probably the shortest bio I've ever seen for Dr. Tam. But I just wanted to briefly introduce her. She is a pediatric infectious disease specialist with expertise in immunization, emergency preparedness, and global health security. And as Canada's public health officer, I think the first woman, right? Right. She has played an instrumental role in helping to guide Canada's response to the COVID-19 pandemic, including the rollout of the largest vaccination campaign in Canadian history. So please join me in welcoming Dr. Tam to the podium.
Thank you so much. It's wonderful to actually be here. And yeah, no, it's interesting to think that one is coming to the end of a chapter in one's career. But of course, I do this in the context of working with very large teams, colleagues from across the whole public health system as well, many of which are many of whom are actually in this room today. So I'm very grateful for that sort of team approach. So I'm very happy to be here on the traditional land of the Huron-Wendat, the Seneca, and the Mississauga of the Credit. And I'm personally from Ottawa. I live, work, play, and occasionally sleep on the traditional unceded territory of the Algonquin and Anishinaabe. So I think we are in a room full of scientific minds and partners and collaborators. So I think all of us are probably of the same mindset that science is essential for pandemic prevention, preparedness, response, and recovery. But it is really, really hard to build the essential functions of science for emergency response during the crisis itself. So science coordination has to be hardwired as much as possible as we're in the interdependent periods and within our preparedness work. So I'll give a bit of a reflection from where I've been working from on some of the lessons learned. Some of it you would have heard from different presenters today, and how the Public Health Agency itself is moving forward based on the lessons learned. And then really, I think some of the focus and importance of community engagement and participatory approaches to our work. So that's the talk. I think there'll be numerous different reports, Walport report at the federal science level, but many others. The agency itself did a lot of lessons learned and self-reflection throughout the course of the pandemic. There was a report put out in 2024. And not surprising, I think, in terms of the components of the areas that we focused on in terms of areas for improvement and strengthening. And I won't go into each one of these, but I think it is really important to recognize the equity approach, which others have already mentioned. It's something that I've been promoting throughout my career, but I think ensuring an equity approach is hardwired into emergency planning and response wasn't actually done in the past. And now we are, I think, seeing some of this being hardwired. But so I'll reflect on some of the ways that we've been trying to do that. A lot of this is to do with governance. There are scholars of governance in this room. I'm looking at Erica. And for whom this will be an area of extreme interest. And I think there's a need to certainly, sort of think about the longer term impacts as well as the acute impacts of the virus and the non-virus health impacts, mental health, chronic disease, as well as the social and economic impacts that people have talked about as well. And a focus on recovery, which I don't think is something that we spent enough time thinking about, and building community resilience. So from the myriads of lessons learned reports, and actually quite a lot of peer-reviewed publications from around the world, there is often highlighted the need for better science integration. So, of course, the lessons are not all new. Some of the data ones, for example, have been repeatedly recommended for decades. So that suggested that, at least to me, that none of these have been really hardwired into the system, even though many people have identified the issues. So after such a disruptive event, there has been some shifts in the Canadian science landscape and indeed globally. I think the federal initiatives like the Health Emergency Preparedness Canada under ISED or Innovation Science and Economic Development in Canada, I think is a welcome development. The name is a little bit confusing sometimes, but it is to do certainly focused on some of the diversification of R&D and domestic manufacturing requirements going to the future. The IHR has its Center for Research on Pandemic Preparedness and Health Emergencies. So these are just two of the new entities that emerged post-pandemic. And I think the key is to ensure that they're sustained and evergreen according to the evolution of what's happening in our society and globally. So, but our pandemic preparedness postures, are lots of things going on, still needs to be more coherent, I think, in terms of a sustained collaborative approach using that multidisciplinary perspective. There's certainly shifts overall in how science itself has evolved over time. And I think COVID-19 has really pushed some of these scientific concepts and approaches and methodologies and values forwards open science, for example, was something that we aspired to before the COVID-19 pandemic, and I think it needs to be further accelerated. We saw some aspects of open science, preprints, and all sorts of stuff going on during the pandemic. But again, these are the concepts and the values that we need to continue to commit to. We've seen a movement towards anti-racism in science and decolonization of science and science systems, and community-based and participatory approaches to research. And there is more emphasis, exemplified by this institute, for example, in working across disciplines and sectors, and including, for example, assuming this One Health approach. So there are some movements, I think, towards the right direction. So the question is, how do we then bring it sort of all together so that it's not a sort of fragmented ecosystem of science? So within the Public Health Agency, we've been trying, well, it is something that I am particularly interested in, looking at a systems-based approach, looking at the components or the essential functions or the mechanisms within that system, unpacking them, and then looking really in a bit more detail at the capabilities and the functions. And so this is how the Public Health Agency has now focused our attention in terms of science coordinating these different components. And we're looking at the principles, processes, and roles and responsibilities within each of these areas. And then underpinning all these mechanisms are an ethics-informed and equity-centered approach. When we are thinking about a holistic approach, this really speaking to the point that these science mechanisms interrelate and they all impact with each other, and they work in a sort of cyclical manner as well. And of course, integration and more holistic approach applies to multidisciplinary approaches. And I think also in the science to policy, part of how we do science, at least for someone who's supposed to provide, written in the Act, Public Health Agency Act, to provide a science-based advice. That advice is coming at me in about 120 directions, and that is not integrated at all. So what I have to do is very rapidly during the pandemic, just try to knit together all sorts of things, working with the deputy minister on, trying to position the advice. And it is really, really hard. So any way and mechanism by which integration of all the different scientific streams of evidence and consciousness flowing towards people like myself would be extremely helpful. So, of course, someone just asked about IfP and is it going to become a pandemic? Well, we're not going to take any chances, first of all. But secondly, that this is a really important opportunity to, having learned some of the lessons from COVID-19, to apply them immediately to the next set of outbreaks and responses. So we did take HPAI, H5 as an example. I'm working with Dr. Sarah Vivek, our Chief Science Officer at the Public Health Agency. So we now have an expert panel, and we've connected intramural to extramural scientists, experts, academia, provincial science agencies, other federal government departments, using a very broad base of scientific disciplines, virology, immunology, social sciences, indigenous expertise, but also this One Health approach. This, as Michelle, I think, said, a really good opportunity for ensuring that the agricultural sector, animal health sciences, veterinarians, and our environmental health experts who deal with wildlife, for example, and environmental sort of detections are part of this expert panel. And so the other thing is that we've published, and I think Canada led globally in publishing a comprehensive list of the knowledge gaps pretty quickly. and it's openly available on the website. CIHR launched its One Health funding initiative in the summer of 2024 to address some of the immediate research needs. NACI, I think, was, if not the first, must have been one of the first national immunization technical advisory committees in the world. It was recognized by the WHO to be the first to put down some recommendations on how one might use an H5N1 vaccine after the federal government applied some of this non-pandemic vaccine. We pull together governance mechanisms where chief medical officers, chief veterinary officers come together in an integrated way. We reviewed our antiviral availability stockpiles, as I said, vaccine capacities. But I think given that we were fortunate that we were probably one step behind the US in terms of the epidemiology, we don't have it in our dairy cattle. It was an opportunity for us really to engage the potentially impacted community. So dairy farmers have never been engaged in the past. Poultry, yes. Wildlife, not enough. So I think if you wanted someone eventually to accept an H5N1 vaccine, now is the time to have dialogues, ask what people's concerns are, under what circumstances would they accept and trust the vaccine. Has to be done now. So this is a sort of diagram from my 2023 annual report from looking at the public health, but essentially a health promotion approach to emergency management. And I think it came out of my thinking more broadly about this era of permacrisis. This is a term that keeps floating around even more. Permanent series of crises, overlapping ones. And I think just like, looking at vaccine platform technologies, building community resilience against all hazards, whether they're climatic or pandemic, has to be a really important focus. So I think I was just looking at a list of all of the new ministers of the federal government. We now have a new health minister. We also have a minister of emergency management and community resilience, which is really, I think, important recognition of just how important that aspect of preparedness is. So in this report, what I call for was a systematic integration of what I would call the health promotion principles, approaches, expertise into that emergency management cycle, right? The full cycle, not just in response, but in preparedness, in prevention, in recovery. And what do I mean by health promotion approach? Of course, in health promotion, we understand that health is created in everyday life, where we live, work, play, do our everyday things is where health is created. So the conditions, the environments, the supportive mechanisms upon which health is built is extremely important to emergency management. And health equity is centered in health promotion because we recognize the determinants of health and the fact that the inequitable systemic factors are impacting different populations differently, as we've seen in the COVID-19 pandemic. A health promotion approach also is aligned with a rights-based approach, including the responsibilities I think all of us have under the UN Declaration for the Rights of Indigenous Peoples, our own acts that are aligning with the international responsibilities and building community resilience through self-determination of Indigenous, First Nations, and Native communities are key health promotion concepts. And then during the pandemic, at least initially, I was noticing that the infectious people are just not sleeping. And the health promotions, non-communicable disease people are actually been quite, we're being sort of surged, thrown into all sorts of different roles. when in fact it was extremely important in the response. Within those teams are the behavioral scientists, the social scientists, the anthropologists, the geographers, the people who understand health inequities. And guess who would be the most impacted during any crisis? The probably people with diabetes and the non-communicable diseases. So those teams have to come together. And there is a need for intersectoral training, interdisciplinary training between emergency managers and health promotion experts. And so I was really advocating for health promotion expertise as part of your IMS. How we now have a box in our IMS that says health equity. This is the absolute function of our IMS, ensure that we have different communities' needs uppermost in our minds. So we saw that kind of approach during our MPOX response, which I think was actually a fairly decent response in that it started with engagement with communities who were most likely to be impacted by the virus. Before I communicated with the public, I asked, well, how could I communicate? What would be a non-stigmatizing but yet empowering approach? So that was really, really helpful. We had trusted researchers, NGOs, community-based clinicians who are trusted by those communities. And it's those voices that were most important in getting an effective response and people get rolling in other sleeves for the mpox vaccines, which we fortunately had the foresight to actually stockpile and the antivirals, etc. So I think helping framing of advice is a really crucial aspect of learning how to acknowledge communities and their knowledge systems, as well as a more effective response. And also, really, participatory and implementation science is part of this approach, and it's very much part of a health promotion science-based approach, where communities need to shape the question and the data. So having it hardwired, and a lot of the CIHR grant requirements now actually have some of these requirements, which I think is extremely important. And of course, making our processes transparent in order for the responses to be trusted. So the Public Health Agency publishes first science strategy post-COVID-19. Before we had science strategies, but they tend to be more siloed and stovepiped on infectious disease and something else, laboratory sciences, etc. This is a much more integrated approach looking at these four priorities, which are very horizontal and more based on those functions or mechanisms. So you can read that. We try to emphasize implementation science, of course. I think one of the previous speakers had talked about, well, you don't have to make, I think it was already in the village, it got to be applicable to the people on the ground. So that's where I think implementation science comes in. And that could be vaccines or antivirals, but it can also be other measures, non-pharmaceutical, that requires an implementation science approach. There is an explicit priority on integrating science and public health emergencies, but all four of these components were, of course, integrated and applicable if you were to deal with the next pandemic. So we also now have established governance mechanisms to try and do this in a more agile way. One of which is our new external advisory committee on science. Dr. Zach is actually one of the members. So trying to build rosters as well ahead of time. We exercise these during different outbreaks, and it's one way of linking academia, clinical and other expertise during normal times into public health. And I'm really looking forward to the agency be able to leverage the wisdom of the expert communities. We also, and Michelle mentioned this, I think, in the process of updating the Canadian Pandemic Preparedness Plan. And I think some of the things that were missing did include, the bit on science integration didn't go far enough, put it this way. It was recognized to be an important thing, but it really wasn't expanded on sufficiently. And I think another really major piece of learning is looking at how we can engage Indigenous partners and experts. So the parallel to the distinction-based pathway was based on us asking how First Nations and Métis organizations and leadership wants to be engaged. And they may not want to be engaged at the same time. You know, we have deadlines, it's like May, you're gonna have, this is the critical path. It should not happen with Indigenous communities where it's finished when it's finished. And it may all start differently on different timings between different Indigenous communities. One thing that we haven't lost, and I think would be expanded on, is the overall goal of pandemic preparedness response, which really is a very difficult thing to accomplish, which is on the one hand, minimizing the impacts like serious illness and deaths from the virus, or the non-COVID, let's just say non-viral pathogen-related health outcomes, while limiting societal disruption and the longer-term impacts. How do you do that? How do you do that from policy decisions? How do you do that in a technical way? Needs to be sort of unpacked. So of course, in the middle, I think I'll just have you focus on that, are the possible themes with science embedded in that, and the other really important principles such as health equity, One Health, communications, ethics built in. And I won't go through all those technical annexes and things about, you can probably guess what they might look like. But science coordination will be built in. And I think many of the speakers also mentioned that the best laid plans, first of all, you got to keep adjusting it because the context upon which the pandemic occurs will change. And not just the scientific knowledge increasing or new vaccine platform technologies that could change the plan, but of course, what's happening in the geopolitical landscape or other things might affect how you respond. And so any of these plans just need to be extremely agile or adaptable, or there's an expectation of that agility. So I'm just going to end on a few additional thoughts. It's not about science coordination or integration. I think it's absolutely true that every pandemic we encounter may have commonalities, but they are probably all going to be somewhat different. And so working on those different scenarios and exercise is really important. Working on the worst case scenario is important, but working on something that is less is equally important because the way people respond and make decisions will be somewhat different. So I think we should do more exercises, especially with decision makers, because how else are they going to, think about what will impact their decisions and how those decisions will be made. The next pandemic may well have a higher mortality in younger people. It was demonstrated in 2009. Most influenza pandemics shift your age group, impacts towards the younger age groups we've seen in the past. So that is not the same as COVID. So when you think about education impacts, well, that is going to be a whole other picture if your kids are sick. And also healthcare workers have to look after their own children, not just their patients, for example. So it really changes how you approach your decision making. Next pandemic may well occur in an AI-enabled world. In public health, we're not that, forward thinking in many ways. And we're a bit slow in looking at the impact of social media. And I think we're a little bit behind, although we're experimenting in all sorts of ways in the application of AI. But an AI-enabled world, if that's the world that the next pandemic occurs in, will give you a whole range of opportunities, but a million other challenges as well. And think about what happens, Dr. Murphy, if you get a vaccine within 2 weeks. Well, 100 days, lovely. And someone's just designed the antiviral that, you know, it's very specific to that pathogen within, you know, a couple of months. I think that operationally changes lots of different things, and it will change how your public health non-pharmaceutical measures are applied as well, because you're titrating all these different components of the response. And your ability to then get people to trust those measures might be quite challenging if you haven't built the trusted networks and your relationship to your communities ahead of time. We don't have enough governance, if you like, or thoughtful and flexible process in which to engage communities in a bureaucracy. And I think we really need to think much more thoughtfully and carefully, particularly on the de-escalation side. So escalation is actually quite quick, and can be quite quick and quite simple. De-escalation is a whole other matter and recovery. And that needs a lot more thinking, whether you're a business or whether you're the health system. Youth was not mentioned very much today. I think someone mentioned the fact that who will the next pandemic impact? Well, it's the next generation of people. We have to build youth considerations, have youth be on our governance committees, be part of our preparedness and response ahead of time, build intergenerational bridges, which are extremely important. Listen to the disenfranchised younger adults who post-pandemic are really not happy with their quality of life and their work, etc. So in this room, many students, much younger than myself, who are going to be, you know, taking this forwards. So I think, but at the same time, trade workers, gig workers, you know, they're also youth. And I think maybe youth to youth connectivity is something that would be extremely helpful. The quote here really is to remind me and everybody that it's often back to traditional ways of thinking. This certainly is something that I think about when I am thinking about health and well-being. It's indigenous knowledge, indigenous science, can often ignite new creative and innovative ways of moving forwards. So I think maybe I'll stop there. Someone mentioned the economy of it all. I'm interested in the economy of health for all, but also well-being economy as one of the next things I'm focused on. So I'll be happy to answer questions. Thank you.
So that was a little trailer, her last comment to her next report. So look forward to the panel discussion. Thanks so much, Dr. Tam, for those thoughtful remarks. And also many things struck me, but I think this importance about having different types of science and dialogue with each other when we're dealing with complex problems, I think is really, really important, and taking an ethics-informed and equity-centered approach. So what I'm going to do now is to invite our speakers from today to join a closing session. So I'd like to invite Dr. Fahad Razak back up to the stage, Roselle Martino and Dr. Ajala, if you could join us as well. Thank you. You've already heard their illustrious bios, so hopefully we can move on to the dialogue. Okay, so I'm going to give Dr. Tam a little break here, and there's some water there for you to have a chance to maybe think from each of the panelists' perspectives, and then I'm going to jot down there and sit down. So while I do that, I'm going to invite each of you to, from each of your perspectives, what particularly resonated for you from Dr. Tam's presentation?
Thank you so much. Chivalry is not lost. He's letting me go first. How lovely. Thank you so much. I tried to give Dr. Tam a cup because I know that we applauded it in the beginning, but I think what people forget is, yes, there was a leadership role, but can you imagine the criticism and the grief you get behind the scenes? There was a lot that happened there, and you have to shoulder that, and you have to keep carrying on. So, Dr. Tam, again, just on behalf of all Canadians, thank you so much. So what really resonated with me is I really appreciated your point about the implementation science. I think that's so critical. I loved your point about the resilient communities, and to me that's where, from an economic perspective, that's where the businesses, would fit in. I guess and I'm not kind of taking out my Toronto Region Board of Trade hat for a minute. I'm just talking about from my experience, because I have a lot of experience in public health, locally, provincially, and nationally. And I really struggle with, we have lots of these conversations. After every situation, after H1N1, after SARS, and even after this one, after COVID, we have lots of conversations about lessons learned, what we need to do, and there's lots of discussion about the what, but we never move forward in how we actually implement it. Like, how do we actually do that in a coordinated, cohesive way? And so I still, that still troubles me, because I say this because I think about, gosh, like there's so many things that we learn from H1N1, from SARS, and again, it's rebuilding over time. And many of those things were not implemented, for example, when we hit COVID pandemic. I'm speaking for Ontario. I can't speak for other provinces or jurisdictions, obviously. And so I really want to, really do whatever my little small tuppence part can be to really ensure that we're also implementing some of those things going forward, and not just talking about it. my 2 cents there.
Thanks. First of all, I can't resist the temptation, since Dr. Upshur is in the audience, to also share with you his term, collective amnesia, about lessons from the past. So I thought that was
Yes, I love that. Can I steal it, please?
No, it's free because
it's so much.
Yes, and so he may just sort of teeing up questions from the audience as well. So, but thanks for sharing those perspectives, Rizal. Can I turn to you next? Hamish, please.
I think that what resonated with me the most was the scientific integration aspect of it, because I think when you're dealing with a fast-moving public health emergency, there's going to be science occurring at a rapid speed. There's a lot to digest, especially if you're in a public health agency, and you have to then take that science and turn it into something that's actionable to present the policymakers. And I think that's part of it, is that science, many of the scientific solutions will be at hand, and it's just trying to figure out how best to package them to have an impact, and also a way that's digestible for policymakers and able to compete with all of the other things policymakers have to deal with during any kind of public health emergency, weighing costs and benefits of school closure, whatever it might be. But when the science is moving so fast, I think, especially in this environment, you have policymakers who will kind of say, oh, you flip-flopped on that science, or at least that happened in the United States, that when the science changes, then all of a sudden the policymakers are not with you anymore. So there has to be a way to kind of integrate the science as well as educate people about how things are going to change during an outbreak like that. And I think there's been less thought of that, I think, in prior public health emergencies as there was in COVID. And I think COVID came out very clear that if you don't have that way of integrating the changing science and presenting it to the public and to policymakers, you end up decreasing trust. So I think it's a good thing that public health agencies are thinking about how to integrate all that fast-moving science to increase the resiliency to whatever event is occurring.
So I think some of the themes that spoke to me from Dr. Tam's very talk was regaining the trust of the public. I think I had a communication role much less than Dr. Tam did, but you did really feel that erosion of trust as the months went by. And then also trying to explain the counterfactual of why a policy that averts the problem is not a failure of prediction, but is actually a success of that policy, whether it's public health measures or vaccines. I think conveying those concepts. And one of the things that I wondered about these last couple of years as we've started to pull away from some of the policies is further strengthening the economic case for public health as being critical to society, strong people, a strong economy, especially when we look at the pressures we're experiencing now. And the idea that we've reached a point where we've left health system capacity be so low that it drives an economic response. So in other words, in Ontario, at least a lot of the articulation for the stricter public health measures during waves was hospital capacity. Well, that was a decision that is many generations in the making, but that hospital capacity meant that we had to shut down the economy or shut down schools in many ways. So I think linking those two things together for the public. I was quite struck by a colleague of mine who's a manager of a large department store in the Eaton Centre, and where they had the use of masks well beyond when mask requirements were required, because they saw it as part of having a strong workforce, and that they had a certain number of people who would work and who knew customers, and if they didn't stop spreading disease, that they were going to lose out on those opportunities. So I guess what I'm articulating is these broader sets of arguments that can be used to try and pull public health back into the center and not have it sit where I think many people sit right now, which is it's over there and it does something when there's a crisis, but otherwise we don't think about it as much.
Dr. Tam, anything you want to comment on that you've heard so far, just to give you a chance?
So I think I can sense frustration, obviously, but I take every opportunity to even make one step forward. So some of the application to the more recent, events, I think is really important because it's going to happen quite frequently. Like measles is your latest thing, so using this as an opportunity to do community engagement, keep building those trusted relationships. A lot of it is subterranean. People are not seeing what's going on the Globe and Mail, but people from local to the public health agency are trying to build those relationships with different communities. Because if you do not, then the reactance could be such that they may not get vaccinated at all. But in any case, there's still stuff playing out in the media that is not always helpful, let's put it this way. So, but I am slightly more, I don't know if other people feel slightly more hopeful about data, but we've got to get that sorted out. Public health has made a case to at least have access to secondary data, because you can see very, very quickly why it's important for that to occur in as real time as possible, because that actually does impact decision making. And there's some political buy-in, because we did have ministers of health, at least all the preceding ones, as part of the federal health transfer and working together, create this priority on digital health and health data. So we are doing quite a lot of work on that front. I'm very sad that we don't have interoperable vaccine registries before I finish this job. It's something that we've been working on for quite some time, and the proof of concept was made during COVID-19. So all that I can say is we can do it. It's going to happen, and that's the only way to move forwards. And lots of people are working behind the scenes. I think it was interesting to me that when the going gets rough, Canadians do unite. So that when adversity is happening to this country, there is increase in social cohesion, which gives me hope. And even in measles, when I go and communicate to people about this illness, which many have not seen before, there is actually some actual uptake. I do not feel that trust was particularly lost for the majority of the population. It's actually reaching the hard to reach through different means. It's not going on TV and trying to talk about measles. It's all the other work behind the scenes, and that is actually happening. I am not that involved in reaching the business community, so it has happened much more, I think, at the local level, but I can see that small and medium-sized businesses in the whole other category to, I think, emergency management organizations like public safety convenes the massive, essential sectors like energy, that type of thing, transportation. That is probably an area that we do need to do more work on.
Well, I think maybe just picking up on that cue, I was going to go the data route, but since Dr. Tam mentioned business, I think Roselle, just based on the hat that you are, one of the hats you're wearing on the stage, can you talk to us a little bit about what was happening, I think, during COVID, this kind of pitting of the economy versus health, and I think from what you were alluding to this a little bit as well, just any sort of lessons coming out of our most recent experience with the pandemic, where we were literally pitting different sectors of society together, and the media has perhaps contributed to that narrative. Any thoughts on that? And then happy to hear other panelists weigh in.
I mean, that was essentially, Erica, the crux of my presentation this morning, is exactly what you said. The bottom line is that that was the tension. We had, I don't know what Charles calls, but we had the premier call us and say, I'm being told that I need to shut down the economy. What are your businesses saying? But that's not how this should be happening. We should not be in this tension where you have health saying we need to the only way to contain the spread and manage the hospitalization, as you quite rightly said, is to lock us down. And you had massive business communities, not the large organizations, because they didn't have the built-in capacity to sustain that resilience. Again, I emphasize a lot about the small and medium enterprises. They didn't have that. And so they were the ones that were pushing and pushing and pushing the government, saying, no, you got to open, you got to open, you got to open. And then you have like this, I don't know, it was like this horrible tension where you created divisions and huge conflict and distrust and actual hatred almost, like you had businesses that hated the health sector, like hated public health. I know, I don't know if Eileen's still here, but I remember Mayor Tory, feeling very protective of Dr. Davila, when she was coming to talk to the business community because they were so angry about public health just doing their job. Erica, I think that's what happened, and I just think that going forward, we need to find a way to mitigate that. One of the ways, as I mentioned, is having businesses ready, giving them as much certainty as possible, having them, be prepared, etc. And I think, as I said, also build that trust. I do want to mention that point because I think there's so much distrust between the business community and health, this health sector more broadly, but also public health. And how do you to build that relationship and say, look, going forward, we're in this together. And how can we work together versus working against each other? Because that's what happened at the end.
Yeah, I just want to add to what you said. I mean, I'm from Windsor, Ontario, which is a very blue-collar town, and the only person in my family who's in the healthcare sector, everyone else is in the auto industry and construction. So I constantly got an earful from people about this during those years, and it was very hard for them to get advice. And I think your point, Steny, I don't know if Steny's still here, we would give briefings to the the Chamber of Commerce equivalent, I had colleagues from my medical school class who became medical officers for Purelator and FedEx and companies like that. So they were okay. It was the small businesses, I think, that really struggled. And I do think that there would be a lot of appreciation from Canadians and on value for public health to strengthen direct advisory to the small business community to answer the 6'4" worker in a small room question that you brought up this morning. I think questions like that. I will say, on the other hand, though, and Amesh brought this up earlier today, your paper, Amesh, about modeling about load sharing, we practically had to do that here. So we had the largest transfer of patients in Canadian history happen in this province. I think more than 5,000 patients had peaked during one wave. It was that close to the precipice, and we saw what happened in New York and in Italy, where the hospital sector did collapse functionally in some ways. So there was real fear, and it wasn't done without that fear. I think people were very, very afraid on the healthcare side of what was happening.
Just one thing, I think that people kind of create a false dichotomy between the economy and people's health, not realize that the economy is people's health, because if people can work, if they can't make something, they can't produce something, you can't make something live. And I think that that's why I kind of focus on the proactivity of health security or pandemic preparedness, that we don't want to be stuck in these false alternatives where governors or premiers are left with very blunt tools and blunt decisions. And that's one of the lessons of COVID. I think that if you are proactive, you don't have to use those, you don't get forced into those false alternatives. And I always by the example of Taiwan, which jumped into action on December 31st, 2019, and did not have to use those blunt tools, much more targeted tools, and didn't have that same thing play out, which played out in Europe and North America.
Yeah, and maybe if I can add, because just from a work and health perspective, and Dr. Tam touched on precarious work, but when those lockdowns happened, what were the social protections that were in place for those who had no choice but to put food on the table and didn't have, sick leave or didn't have any social benefits? And so there's this precarious underbelly that we have to bear in mind as well. I want to, before I turn, is there anyone who has a burning question? And I'm not sure who has the roaming mic, but if anyone has a question, just perhaps wave down someone, and I'm happy to take the question. But I'd like to just come back to a point that Dr. Tam was getting into, which has to do with data, and we won't talk about the vaccine yellow card in Ontario right now, but I will resist the temptation. But I did want to talk a little bit about the opportunities for data collection that were created during COVID. One of the, I think from an Ontario perspective, and certainly I can't speak for other provinces, but there was a strong push, and it wasn't a new one, but I think COVID opened up a policy window around collecting better race-based data, which we're not very good at in this country. And so I guess I would love to hear from any of you, and certainly from our colleague from the U.S., because you do collect this data in the past, and it comes with great responsibility as well. How are we building those lessons from data collection during COVID into our future surveillance efforts, and what does that look like? So Dr. Tam, I don't know if you want to take this one or anyone else, because, or speak more generally about, learning about data, because the Naylor report certainly talked about the need for better data sharing agreements. That's the report from 20 years ago. I know we've made some progress, but it's also what data, right? If we really want to center equity, as I think your presentation really nicely highlighted. So any thoughts about that, and anyone else on the panel?
So I think some of the basic foundational approaches, of course, means standardized, having standards, looking at interoperability. So those are the areas that we really have to accelerate on. But I was really struck by the fact that in some countries having a unique identifier has been really, really helpful. No one wants to go over the demographic data, the race, etc., when you're in the emergency room. That data should be there so that along with your medication, your lab tests, so that it is part of the integrated patient summary, if you like. But people shouldn't go off and just all do different things. I think if you can actually come down to the buy-in to get that sort of patient summary approach with the standardized data that will allow you to disaggregate, the non-nominal data, that will be really, really helpful to public health. And that involves public engagement, and so there is a group with the Public Health Data Working Group, for example, that is looking at public trust and engaging the public in a methodologically sound way, linked to academia, on how we engage the public on data and what's the value it brings to them and to the population.
That's really helpful. Can I just do a quick follow-up? Sorry. Just a really, really quick follow-up on that, Dr. Tam. So just an example, I really love that point about the public trust in data because from, again, a business perspective, there were a number of businesses, startups actually, that were trying to be creative during the pandemic, and they were coming up with different approaches to, capture, build vaccine registries and all sorts of stuff. One company, I think they're still in business. Switch Health was one organization as an example, and I think there are others. But the trouble they ran into was they couldn't get the data. They couldn't have access to the data. It had to be anonymized. I get that, but that's where they ran into the roadblocks. They had these wonderful innovations. They were using advanced technologies. Looking at different apps, it get really quite creative from an innovation perspective, if you will. But they hit a roadblock. And again, I think that's a really good example of trying to bring into public engagement to build that trust about data, because what is it being used for, and how will it help in a broader way? I think that was a big disconnect, because we held a lot of focus groups with different businesses and their staff to understand, hey, would you give your vaccine information? Many of them were willing to do it, they just weren't clear on what it would be utilized for. And so, again, that's just one example, but I really appreciate that point.
Thanks, Rosal. And I think those are the kinds of things, I've been negotiating during the pandemic because, so I think, again, how can we start to build that trust, that public engagement, but to do it in an ethical way as well. So, and then I'm going to look out to the audience. Is there a question at the back? So I will go after this one comment. We'll go to the back, and then I see Ross has a question as well.
Is the song? Oh, perfect.
Okay, can you just wait for 1 second? Sorry, Fahad was just going to make one comment. He's been really patiently. Thank you.
Right. Yeah, I'll just say briefly, when David Naylor wrote the Naylor report, the interoperability problem was a technology problem. It is absolutely not a technology problem today. So it's purely a political will, public will culture problem. I'm saying this as someone who's pre-pandemic and now post-pandemic research career is strictly about health data. So I'll say that as the first point. So it's really, does the public want it? And fundamentally, there is a social compact around data. So when you get onto the Gardner, you have a social compact. 100 kilometers an hour is not a scientific number. That is a number that we socially accept. There's a speed limit, and there's a balance between accidents and needing to get where you're going. Right now, the social compact around health data is closer to 0 kilometers an hour, and that means it's purely safe, but in many ways you don't get to go where you need to go. So that's the problem right now with health data. And I do think that we need to articulate the losses more to the public. And if you look at behavioral theory, data economics, prospect theory, we talk a lot about the promises of data, but we need to articulate to the public what they're not getting because of that data, the inequities of care in other areas, because I think there's clear loss now. The second thing I'll say very briefly about race is as race and ethnic data and social demographic data. I lived in the U.S. for 5 years, and I was very struck by just how routine it was to measure these things as part of a healthcare encounter. I'll say this as a non-white person, there's no perfect conception of race and ethnicity. It doesn't exist. It's all an approximation, and it will never be perfect. And I think waiting for perfect is doing a significant disservice to communities who clearly are doing worse, but not in a measurable way because we don't have good data. And if you look at drug access as just one example, the second life-saving drug that was developed for COVID was highly constrained. This was one of the IL-6 inhibitor. We ran out in Canada. We ran out. I was one of the prescribing physicians. We just ran out of it. When you run out of a drug, you, of course, know that the people most likely to give that final dose to are people who look and behave more like you, higher income people from these neighborhoods. In the U.S., they clearly showed that happened. I suspect that happened in Canada, but we can't show it, just as one example.
Thanks for that. I'm going to go to the back, and then we'll come to Ross next. Thanks for waiting.
No worries. I'm really glad, actually, that the conversation turned towards interoperability, because that was exactly what my question was going to be about. I know that Tam had mentioned it, and of course my work is on cluster data, and I'm really curious as to know, I think there were some things that you mentioned that was going on in the background with an interoperable health data registry, and there have been some more conversations about it. I'd love to hear some more information about how that is progressing and when we might be able to see that, or how we might progress towards that state. Of course, it would make my work a lot easier.
I can start. I'll say that Ontario is the most challenging environment for health data because hospitals across the street from each other, you can throw a rock from one hospital to another, but you can't get data to interoperate. Again, historically true. There is a functional model, I'm the co-lead of that's funded by the Ontario government, that essentially crosses the province down. That's functional 10 years of history of that data being used. So it's really not an interoperable problem anymore. And then there's provinces like Alberta, Nova Scotia, which the entire system's on one health record now. So the reason why the data doesn't flow is because the provincial jurisdictions are political barriers. Of course, there's no physical line that prevents that data from flowing. And then within institutions, within a province like Ontario, there hasn't been a centralized push by the government to force the sharing of that data. And then that boils down to individual institutions which are risk averse and think it could be monetized and all the other reasons, and it doesn't flow. So again, culture of politics rather than technology.
Thanks for that. Ross?
Thank you. First, I'd like to thank Nelson and everyone at the Institute for Pandemics for putting on a wonderful day, and for all of the speakers for their enlightening and informative contributions and presentations. So I've heard a lot of, I'm not going to ask about what the least unit of collective human memory is, but I want to ask about, so there's a lot of focus in the discussions about the importance of science, without actually acknowledging two things. One is that during the pandemic, there was a lot of wasteful science, a lot of duplication, no trials. So maybe Fahad or Theresa, you can talk about how future strategies to provide good quality science, but also to recognize that science is only going to get us so far. I've been an academic researcher publishing for 30 years, and I've never concluded a paper without saying more research is needed. So because science is an open-ended ecosystem and decisions need to be made under high conditions of uncertainty, how is it that we're going to use Theresa's language, hardwire excellent scientific capacity into our responses? And is the time to do it now? One of my frustrations was, we had, I thought for the first year of the pandemic, so I was sitting on the WHO R&D blueprint team, that the entire pandemic was about the spike receptor or the intensive care, when all of the action was out in the community. So how are we going to get research embedded into communities to give us the answers that we need? Can we invest in platform adaptive trial capacity across Canada so that we can ask and answer questions that we need to answer for non-pandemic conditions that can be rapidly converted in a crisis? And a good example is sequencing. So I was at Sinai and Runenfeld, and a sequencer is a sequencer. As long as it's genetic material, they can sequence it. So all the cancer researchers stopped sequencing cancer cells and started sequencing virus. So they have that kind of adaptability and flexibility. And, one of the major advances besides mRNA vaccines is our capacity to, in real time, sequence viruses and find out about mutations. So how do we build reliable, dependable scientific capacity into systems that can be then turned on or switched over to use in a pandemic? Thank you.
Dr. Tam, do you want to pick this up and then follow?
Yeah, you partially answered the question yourself, I think, and I would agree. I think getting so from a public health perspective, our role, I think even starting from now, is just to outline the research questions, for example, which questions are awfully important to drive the public health response can probably be envisaged right now. It happens with the most new pathogen, I think, where rapidly doing that, but also having the rapid funding mechanisms then can flow to existing networks. So I think building as much as possible those capacities and networks ahead of time, of course, is I think, way to go. As we're sort of thinking through H5, we're capitalizing on some of the existing networks for vaccines and for looking at social behavioral science and things like that. I think is really helpful because then you're building and testing those capacities in non-pandemic times. But I think CIHR, for example, have a new pandemic center. I think I'm certainly hoping that those centers of gravity is there now to keep going at building out those sort of capabilities, including REBs. We talk about these things, endlessly, but I think creating the necessary environments for multi-centered clinical trials or other constructs is going to be extremely helpful, I think. The participatory methodologies and mixed methodologies have to be built now. And I think that's the bit that I feel isn't quite there. Although I think the grant applications now, and you've seen some of these catalyst grants, are actually hardwiring the requirements for community participation, participatory research, I think is a good way. But there's lots of things that I think can be done ahead of time. The platform technology concepts can be applied equally to the scientific system, I think, that can be handle all hazards, if you like. But there's still a lot more to be done. One thing that I was just thinking about, given the previous response to the question, is to earn public trust, what we're hearing is that people need operational transparency, not just the decision itself or your recommendation, is how on earth did you make that recommendation? And also, really that being part of it, the actual participation in how that policy is shaped. So how do we, set this up? It's actually functional when things are moving at a really, really great speed. I'm going to look towards activists and others to help us in that. But it's the trade-offs. I was thinking every policy has trade-offs, and we've been talking about a lot of those. How do we get the public engaged in what are really, really difficult decisions that always have these trade-offs that are in tension with each other? And that's when you really need the public, I think, to get engaged.
Yeah, I'll add briefly because this was a big focus for the Whopper panel. And I think we can really learn a lot from the United Kingdom in this regard about that coordination and what can happen. So the ability to have a top-down approach to say these are the priority research questions meant that they were able to answer questions at lightning speed. And for example, we had clear evidence that dexamethasone, the first life-saving drug, worked before the second wave hit. And the estimate is that millions of lives were saved globally. That is purely, essentially, UK evidence. And then they just systematically knocked down each question that people were wondering about. And at one point, I think, 80% of all patients in the big trials globally were just from the United Kingdom. So how did they do that? They essentially set priority questions. They said all funding is going to these priority questions, and that was set by a committee like one that could sit at the Public Health Agency or at CHI. They had a centralized committee that just set the research questions. The second thing they did is they insisted on a common RAD, and they said if you're going to receive funding, you're going to use this RAD. They set benchmarks for how fast patients had to be recruited, and they had a non-shared legal agreement. So they essentially said if you want to participate in this research, you will follow these things, otherwise you won't get funding from us. And that was the stick that forced academics to follow the model. I will say that part of what can be transparent, what's really one of the positive things that Dr. Tam mentioned is that the new CHR strategy is moving to that framework. So forced condition of funding, that you follow a common RAD, that you have a common data sharing agreements. Back to the loss framework idea, I think one of the things that I often would say is that I think of my 80-year-old parents, and if they were in the United Kingdom, they were between 5 to 10 times more likely to be offered a life-saving COVID therapeutic than they would have been in Canada. That's the dramatic difference that occurred because of that coordinated research. It means right now they have a cancer screening trial in peacetime of 150,000 patients. That's 2 years of follow-up that was done in 1/3 the time over conventional trials, so using that same structure. So I think it's articulating those kinds of things that Canadians are not getting today, but could if we did this coordination. And again, I don't think we have to invent a model. There's one sitting on the shelf right now we can look at.
Sorry, just a really quick follow-up on that. Ross, I think that your approach that you're suggesting is a great foundation for what Dr. Tam spoke about in terms of enabling that operational transparency, which will ultimately lead to public confidence and greater public trust. And the integrity, so, Dr. Tam, you spoke about, it's not just about communicating what the policy is, but what led that, and how was it shaped, how was it informed. And just to really give a tangible example, and I hope I don't get myself in trouble for this, but too late now. You got the one. Thank you, Erica. Erica and I went to university together, so I can be a bit naughty. Just to say that during the episode, I was telling Dr. Crispin earlier, actually, we called the Italian Chamber of Commerce in Italy, because that's where a lot of the cases were happening, obviously, to understand what were they doing. So again, I have to explain to you, you're having a lot of trouble getting information. And again, thankfully, I was able to connect with Stacey and Eileen and others who helped me in my endeavor, as I talked about this morning. So we called the Italian Chamber of Commerce in Italy, and we're I'm trying to ask them, what were they doing? What were their businesses doing? How were they looking at how they were reopening, et cetera, et cetera. And so I told them about the 6 feet distancing rule and the bubbles, and they laughed. And they said, there's no evidence for that. What evidence are you using? Where are you guys coming and where is this coming from? And so I'm just thinking, so then that became really difficult to be able to say, oh gosh, this is what the evidence, what the science is telling us, this is what the evidence is telling us. And you have other jurisdictions laughing at us. Sorry, that's not meant as a criticism to anybody who might have come up with that. I'm really not saying it that way. And you have to do what you're doing at the moment, right? You have to fly the plane, build the plane, land the plane, do everything at one time in the middle of the pandemic. And I know it because I've lived it. So I really am not saying that as a criticism, but I'm just saying this is about going forward. Those are exactly the kinds of things that led to mistrust and from the public and really low public confidence. So I really think your approach, Ross, is a great foundation. And exactly what Dr. Tam said, I think that's exactly what we need to do going forward.
Okay, well, I'm getting the proverbial hook here. I'm sure we could continue to discuss, but just on behalf of all of you in the room, I just want to thank, first of all, Dr. Tam for providing very thought-provoking remarks, and to our 3 panelists for a very interesting discussion. And And hopefully Canada will come out of a period of somewhat arrested development and implement also what we know. There's something called the no-to gap, and I do think that there are some important models we can learn from and not necessarily reinvent the wheel, as you mentioned. And so thanks, everyone.